I'm back. Hey, what's up, y'all? It's Dr. Italo Brown, board certified emergency physician, and this is Med vs. Movie. Now, on the last episode, I was breaking down season 1 of The Pitt. All right, I get it. Season 1 of The Pitt was wildly successful. It's something that I feel like I saw coming from the beginning. One, because who doesn't love emergency medicine? And two, you got some crazy scenes with amazing actors thrown into the mix like a gumbo. Everybody wants to scoop. So I got it. I'm glad y'all got it. Hold up. Spoiler alert. If you haven't watched this week's episode yet, stop right now, go watch it, and then pull back up and we'll talk about it all together. All right? Let's do it. Straight from the jump, one of the first things that I recognized by watching this episode is that your man Robby clearly is a rebel. He's riding through the streets without a single helmet on. The man has a helmet on his backpack when he comes through, so I know he understands it, but it's clear that he kind of is a deviant when it comes to some of the rules. And that really corroborates a lot of what the character kind of demonstrates throughout season 1. And I think it's cool as a touch to add basically him coming in the exact same way. He, gives a quick acknowledgement to the EMS folks. Shout out to my EMS people out there. You already know I love you. And so it really gives off this vibe of like, we're all in this together. We're a family, and this is a very special day. And for him, it's special for an entirely different reason. But let's get into a little bit more of the episode. They start off with two things that I think we have to talk about off the rip. First and foremost, shout out to all my sim fellows, my sim people. Sim makes the world go round. If you ask me, we learn so much from doing simulation in emergency medicine. I mean, it's its own fellowship. There are so many cases that people have seen or gone through, and they've reworked it to be a simulation. And that teaches not just the persons who are in that room, but it can extend to multiple programs. In fact, there are physician associates, nurses, almost anyone in the healthcare workforce. They do simulation exercises to better understand like the steps and the protocols involved with treating a patient in a very complicated case. And so opening this with that particular dynamic, chef's kiss. Now, one of the questions that I get often from the comments is like, how does one tell like who's who among the characters? Now, obviously the characters got different names and we've fallen in love with certain personality types, but I want to stick to some of the technical pieces around residency and training. So the arc of training is a little complicated. And why I like this episode a whole lot is because it's like starting at the beginning of the academic year. That's right. For most people, the year starts in January, but in medicine, the academic school year begins in July. And so if this is taking place on the 4th of July, you can expect to see brand new residents, brand new interns, brand new medical students, and in this case, a brand new attending. And so I think that that's going to add some more complexity and dimension to the mix. Just so that we're all on the same page. If you hear them say MS1 or MS4, these are med students, or an M4, that is a med student classification. So M1, 2, 3, 4. And then you got your R's. So R1, 2, 3, 4. In some situations, it's a 4, but these are resident classifications. And this is a 4-year program. I can tell that because he talks about, again, graduated responsibility, which is a term that we use in academic medicine to denote when you kind of like move your way up the ladder and you get more responsibility, more ownership over patients. You get trusted differently than someone who's brand new. And you can mostly run the department with minimal oversight. You see a little bit of that in the episode. Your boy Langdon is back. He said, I'm back, on the block, man. And this is a very unique dynamic. Somebody who has a substance use issue and is returning after some sort of administrative leave. I've seen this happen in a number of situations. One, I worked in an organization that reviewed a lot of these cases, and we would hear about somebody having some sort of like either behavioral issue or mental health issue or a substance use issue, and have to review whether or not the case was valid, and then talk about like the next steps and courses of action. So I like that this episode picks up right after he did his administrative leave. He's gone through some of the substance use rehab programming, and now he's back to treating patients. I know that some people feel like that's a little controversial, but in reality, usually this is more than 3 months. It's like a 3 to 6 month period. And it is also subject to re-evaluation. So I am very surprised that they kind of fast tracked this. Also, the fact that he comes back and is expecting to go right into his normal role and responsibility, and he gets gut checked real quick. That to me is classic, and I'm not mad at it. Shoot, look, go see the patients in triage. You might be drawing blood at this point. Y'all know how much I love a good procedure. So what they're showing you is that they have a patient that's brought in with a stab wound to the right side of the chest. Now, these penetrating traumas can be very, very bad. Even though it doesn't seem like it's in the location of greatest concern, anything in this general region is concerning, it's problematic. And so you have to act very quickly. Penetrating trauma to the right chest, I'm already concerned because, look, we know where this is going. Penetrating trauma, no pulses, is going down. It's going down. It's time to cut.
Coming for me while I'm gone.
So nice to meet you. That time they replaced you, rabbit bitch?
Hey, man, they bringing it back.
Dr. Garcia,
You got to do the compressions a little deeper than that, dog. That ain't it.
1, 2, 3.
All right, the transfer is right.
I'm on it.
Mm-hmm. Great call out.
What's up, white chocolate? Did you know?
Not white chocolate. My man Whitaker is now white chocolate, boy. He said, you know my name, call it.
What's your plan, Samara? Chest tube to the right. Stand by with master transfusion protocol.
I put 2 units on the infuser.
Excellent.
Steroid blood 6.5.
Here we let the fellows and the residents kind of take charge.
I'll hold on to them just in case.
Yo, I can tell Robbie's annoyed with this person. I get it. Hold on, pause. Like I said earlier, July represents the beginning of the academic year. And in some cases, that means you have new hires. Those new hires can be attendings, and the attendings obviously come in with their own gestalt, their own way of practicing. And sometimes it is like dipping your toe into the waters to understand like how to manage patients at that facility. So there's always some institutional growing pains whenever you come into a new system, and especially if the stance is you're being brought in to do a specific task. So I think that this is very interesting to bring a new attending who has an entirely different way of approaching clinical cases, resident education, medical student education, quality control or quality improvement metrics, like all of even what's called Press-Ganey scores, which is hospital satisfaction or patient satisfaction scores. Like this to me is the most accurate representation of some of these new attending, new hire dynamics. And so let's just keep watching. And so what you first start to hear them talk about after they get the vital signs and get access is what are they going to do? So Robby is trying to let the residents kind of work their way through the problem. And the new attending, as I'm going to call her until she has to be initiated through the Met versus movie family. We gonna call her the new attending for right now. But she is almost like directing them on what to do. And a lot of times that can encroach upon the structure of resident education. That's one of the things I have the most difficult time with when I'm working with residents, is because I am eager to jump in and say, do this, do that. But really you have to kind of work in a very sophisticated way, allowing them to make logical conclusions. And right before they make a misstep, you're there to correct them, or you're there to encourage them to do a different thing or think about it in another fashion.
Is the VA even a trauma center?
Not for medic runs, but
Look,
they walk in.
no shade, but if you're not working at a trauma center, sometimes I got questions. Like, do you really know how bad it gets if you're not seeing this more frequently? All right, we got to get into this clamshell. So in this scene, what they're doing is basically creating an incision so that they can get greater access to the chest. And that is with the intent of seeing whether there is a place that they can actively like staple up, or if they can intervene right now. The chest tubes are going in at the same time. Spreader pulled out, perfect. It's a lot of blood coming out of this tube. I'm worried, yo. This person got to go to the OR ASAP. All right, so in prior videos, I've talked about what happens when you open the chest. A lot of times what you're trying to do is gain access to the heart so that you can provide manual pressure in what's called a cardiac massage. And part of this process is like very structured. So you hear cross clamp the aorta and all of these different steps, which are accurate. What I think is really unique in this scene is that they notice that the bleeding is coming from the right side of the chest, and it's actually coming from one of the hilum or the hilar branch, right? And so on that right side, it's where the bronchi split out, and this particular hilar area is particularly vulnerable to deep penetrating strikes from any type of an object.
You're gonna rotate the lung 180 degrees, like putting a king in the garden hose. It'll stop the bleeding.
That could possibly work.
Or he'll die when you rip the entire lung off the hilum.
And what he suggests is to take the lung and basically do 1/2 turn of that lung and create some sort of a tamponade effect, like to cinch it down, almost as if you are kinking a garden hose. And so I think that's just so sophisticated and really incredible. I'm sure there are a few case studies that talk about doing this, but it is definitely not common practice to open the chest and then flip the lung. I'm actually on the side of the new attending here, like, yo, we can't just do this. But again, you know, give them a rope, they're gonna be a cowboy. And that's what Robby is. He said, yo, I know what I'm doing. Let's cook. Slick. He talks about doing the massage with one hand, pressing up against the breastbone. That is, if you do not have direct access to the heart, you can use the breastplate or the breastbone as a fixed structure to kind of like get that traction and get that pressure.
Gently. Very, very
Hilar
gently,
Flip.
very, very slowly.
Hilar Flip. This is one of the coldest things I've ever heard. I love it, y'all. I love what we do. Yep. Oh, man. Beautiful.
Blood loss is slowing
Beautiful.
down.
Good sign.
Hilum looks dry.
The heart feels empty.
Okay, we fixed the leak. Now let's fill the tank.
And so right after they do the Hilar Flip, you recognize that they're talking about the heart feeling like it's empty. And that's because all the blood that you see coming out of the chest tubes and that's in the chest cavity has just basically been transfused and gone out. And so in some of those cases, people will auto transfuse. So they'll take the blood that's come out and then retransfuse that into the patient. But really what it is trying to, as soon as possible, fill the heart back up with enough blood to perfuse the other areas of the body, namely the brain. All right, so this is like 4 or 5 things in one, and I want to make sure I get this. So when they show the heart, it's basically quivering, it's moving in a dysfunctional, disjointed fashion. That is representing a fibrillation. And so they want to shock that rhythm. And when you have the chest exposed like that, normally we think about shocking with putting some pads on somebody or putting, sticker on the front, sticker on the back, and then delivering a shock. But in this case, there are small paddles that we have where we can put them directly onto the heart and deliver that same shock. Super sophisticated. It's usually a last ditch effort, but here it works. Man, you gotta love it, y'all. Gotta love it. Yeah. Pause. So in this portion, they talk about a POLST, and I think that this is one of the most incredible, nuanced things that this show is doing. It's introducing medical terminology that is current, that many of us should be aware of, whether we are clinicians or not. And a POLST is one of those things. So by definition, a POLST is physician orders for life life-saving treatment. That's right. Essentially, it's advanced directives. It's whether or not a person is okay with being intubated or resuscitated, whether they want life-saving measures like fluids or antibiotics, if they want chest compressions, if they want pressure support. Like, all of these different elements go into trying to sustain life, save life, or extend life. And a person may have a different wish, and that can be clearly stated and documented in a POLST, and it travels everywhere you go. So that's kind of like the main characteristic of that document or of that statement. And the fact that they highlighted this for the patient, I think honors like a real issue that happens in emergency medicine, but also kind of like exposes the audience to the complexity of whether or not you should just save somebody's life simply because you see that the situation is grim, or that they are losing pulses, or that their vital signs are irregular. In some cases, you have to just honor the patient's autonomy and their decision. And that's what this here is kind of demonstrating and bringing to the forefront. This episode is jam-packed. I just wanted to give you all a taste. I'll continue to break down the episodes throughout the season. I'll also go back and talk about some of the cool things in this episode. So make sure that y'all stay tuned. Like, subscribe, follow Med vs. Movie, all right? Until the next time, y'all. Peace.